fact that we are going to be looking at the Chapter 19 review for your exam.
Mm-hmm.
Got it? With all the different things. So if you guys can call these out to me as we're going through it, I'm going to go to the PowerPoints and show everybody where the answers are.
Okay.
All right. So let me switch to the PowerPoints. Of course. Let's swap it. There we go. All right. Okay. Now, as you notice, the questions, the statements are out of order from the way your PowerPoints are written. That's on purpose because you go to the review because you already know the chapter. Got it? The original study guide is in order. Okay. I get emails saying, why is that? This is why. All right. So, what was the first question, my friends?
Know the function of the vagus nerve.
Okay, the vagus nerve. Which cranial nerve is the vagus nerve? Okay, remember, there's 12 of them, right? And there's a little mnemonic I taught everybody in 210. On old Olympus tiny tops, a friendly Viking grew vines and hops. So the only V's are number 8 and number 10. Well, is it 8 or is it 10?
10.
It's 10, because 8 is the vestibulocochlear for your ear. So it's number 10, all righty? And what nervous system does the vagus nerve work for?
Parasympathetic.
Parasympathetic. It is the number 1 rest and digest nerve. Got it? So, what are the 2 things it's responsible for? Making your heart rest, but making your digestion speed up. Got it? Rest and digest. So, we can take a, let me turn this on. We can take a look, and there is something in here about vagal tone. Anybody know where that is? I know it's got to be running somewhere. I know it's in here. It's coming, it's coming. Cardiac cycle. Okay, it's in here somewhere. I just remember seeing it. But anyway, this sets the tone, okay? In other words, I know where it is. It's where we have our, okay. You have 2 nodes in your heart.
Mm-hmm.
Got it? Now, that is not a nerve. This is a muscle group. Alrighty? But these are called what? Autorhythmic, meaning they set their own pace. They decide when to beat. 10-4. All the rest of your heart muscle is contractile, meaning they contract, but they're told when to do it. Alrighty? Now, this is the main one, and it's called the SA for sinoatrial, meaning it's in the sinus, the hollow part of the atrium. Right? This one is called AV because it's right where the atrium and the ventricle meet. Alrighty? Now here's the thing. The SA node wants to fire at 100 beats a minute. The AV node wants to do 50. Why is our heart rate 75? It's not the average. It's 75 because the vagus nerve says, I want 75, and you will do what I say. Okay? Does that make sense? Now, what is the heart rate of an Olympic athlete? 75 beats a minute? No, more like 35 or 40 beats a minute. Very slow. Why? Because their heart is very efficient. It takes in the blood, it sends out the blood. Got it? They have a lot more blood vessels, so they can, because they've grown those with exercise, and there's more capillaries delivering more oxygen to the tissues. Got it? So that's why their heart doesn't have to beat as fast as 75. 10-4. And understanding how this works allows us to understand what a junctional rhythm is, which is one of the questions coming up. Okay? All right. And we also need to understand that there's a delay between these two. What you talking about, Willis? Well, if this one fires, he's going to immediately tell the two atria, squeeze. Got it? When this one fires, it sends messages down these two nerve branches and tells the ventricles to squeeze. Do I want them all four squeezing at the same time? No, because I got to squeeze these first to do what?
Get the blood.
Get the blood into the ventricles. Then once it's in the ventricles, then I can squeeze the ventricles. Does that make sense? So we have to have a delay between the SA node firing and the AV node firing. That 0.1 second delay is enough to get the blood down into the ventricles. Does that make sense?
Yes.
Okay. What's next?
Know how you do how you calculate cardiac output.
Okay, cardiac output. Now, please be aware there's no math on the test. Okay? What we're doing with this is, do you understand? Yeah, here we go. Cardiac output. Do you understand what the concept is? Okay, that's what we're talking about. Cardiac output is this equation. How much comes out of your heart is how many times your heart beats times how per minute, and how much comes out per minute with each beat. Got it? And that's how much comes out per minute. So how many beats times how much comes out is how much comes out in a minute. 10-4, which is a pretty good bit. Does that make sense? So the only other thing I could possibly ask on a test is what's the relationship between these three? And because they're all in the numerator, they're all above the line, it's all direct. Got it? If stroke volume goes up, so does your cardiac output. If your heart rate goes up, so does your cardiac output. Because they're all in the numerator position. What kind of equation would have an inverse relationship? Something like velocity is distance over time. See? If my distance goes up, my velocity goes up. But if my time goes up, my velocity is going down. See? And the difference is numerator, or numerator versus a denominator. And that's really the beginning of understanding math the way the Greeks came up with it. All they used math for was to explain nature. And their belief was, in nature, when one thing goes up, the other thing goes up, so let's put them above the line. In another situation, if one goes up, the other goes down, let's put the one going down under the line. That's it. And that line ended up becoming this designation of numerator and denominator. Make sense? Mm-hmm. And later on, we realized, hey, that's a multiplication, and this is a division. Got it? We just kept adding a little more intricacy to it. All right? How's that? But as my students asked last night, is there going to be a calculation? No. But if I gave you 4 versions of this, could you pick the right one out? Got it? Okay. What's next?
Be able to explain the Frank-Starling law.
Frank-Starling. Okay.
And the brain breathing.
That's definitely on there because that's the one that a lot of students get mixed up. Okay. So let's go to Frank-Starling. See him right there? Okay. To understand Frank-Starling, we need 3 words to be understood. A preload, an afterload, and contractility. All right? Now, just like Mr. Smiley here, if you're at the gym, what's the load?
The weight?
The weights. Got it? And the weights, let's say the weights are down here. Is this after you've moved them or before you moved them?
Before?
That's your preload. And what is this?
Afterload?
After you've moved the load. Got it? Well, your heart's not pumping iron. Your heart is pumping blood. Got it?
Yeah.
The volume of the blood is the load. All right? So, here's how we look at it. This is before we move the blood. That's when we're filling the heart, right? When we're filling the heart, what are we doing? Stretching the heart out, right? When we empty the heart, aren't we? That's the contractility. Got it? So if a little bit goes in, it snaps back a little. If a lot goes in, it snaps back harder. Does that make sense? So you'll never guess the fastest way to explain Frank Starling law. Here it is. The more goes in, what?
More goes
The
out.
more goes out. Just like stretching this rubber band. The more I stretch, the more it snaps back. The less I stretch, the less it snaps back. Does that make sense? So, this is based on the fact that increased venous return from exercise stretches the heart muscle more, exercises the heart muscle more, makes the heart contract harder, and that's what makes your heart more efficient. Therefore, exercise is what the doctor is always saying you need to do more of. I've never had a doctor say, oh yeah, sit on the couch more, watch TV. No, get off here and do something outside. 10-4? Okay. And, gosh, with the weather getting better, I'm going to go cut the grass this afternoon when I get home. It's nice. We had the windows open last night. It looked beautiful. All right. Cool beans? All right. Now, who is next to the Frank Starling law in the same question?
The Bainbridge.
Bainbridge.
Bain-
Okay.
Bainbridge.
So, Dr. Frank and Dr. Starling, in fact, my nursing students say it's just called Starling law these days. I think Frank fell out of favor. They kicked him out. Okay? Well, guess what? Here it is. What does the Frank Starling law talk about? What am I stretching?
The wall of the heart.
But which chambers?
The
The ventricles. Got it? It's the ventricles. Oh, and by the way, this is kind of cool. In nursing school, that's what they use. There's a website where they have all these diseases and all these conditions in the form of a little drawing. Got it? But is it what's going in equal to what's going out? Yeah, that's what we're talking about. Okay? So, well, what did we say the Bainbridge was about? It was about the atrium. Let's sum this one up real quick. The more in, the more out. Because the Bainbridge reflex says, as we put more blood into the atrium and it stretches more, it then squeezes harder to push it down to the ventricles. See, they kind of work together. Does that make sense? And how does my atrium know that it's been stretched? With these baroreceptors. They're realizing there's more and more pressure. Remember, barometer is the pressure of the weather. There's increased pressure, and that causes in the atria and stimulates the heart to beat faster and get it down into the ventricles more. So they go hand in hand. Does that make sense? Was there another word after that?
Not on, like, for
That was it, just
Bainbridge.
Bainbridge reflex and thing? Okay.
I know in the PowerPoint you put atrial reflex or Bainbridge, but
Yeah. Okay. Cool. Does that make sense, y'all? Okay. What's next?
All right. Explain what happens during isovolumetric contraction.
Okay, this is a cool one, and again, not the biggest, most important thing in the world, but I know they mentioned it in nursing school. What's the prefix iso? Same. Remember, like an isotonic solution? It's the same outside as it is inside the cell. So, What's volume? The amount of liquid in the heart, right? Amount of blood. What's metric mean?
Distance or
Yeah, it's a measurement. Okay? It's a measurement. So, what are we saying? The heart is doing what?
keeping the volume the same, or
Yeah, while what's happening?
it's resting?
No, it's not resting. It's called isovolumetric what?
Contraction.
Contraction. So it's not resting. What's my heart doing? It's actually squeezing. Well, let's get back to a picture of the heart. Is that good enough for you to see the outline of the heart? You see, my friends, these two are squeezing to get the blood down, and then these two are squeezing to get the blood out. Make sense? Well, guess what? For a moment, between these two, the heart is squeezing, but all four valves are shut. And that's why the volume isn't moving, because nothing's coming in and nothing's going out yet. Got it? So that's the key. Isovolumetric contraction is when all four valves are closed. It's to build up the pressure. Remember, when I put the blood down into the ventricles, don't I have to close these? Otherwise, it'll go back up, right? So they're closed to keep the blood here. But before I can push the blood out through the pulmonary trunk and the aorta, I need to what? Push enough to open these semilunar valves. And it's that moment that all four valves are closed. They're closed at the top to build up the pressure, and the ones for the semilunars haven't opened up yet. And that's all. And that's because there is a part on one of these EKG kind of things where the pressure is building and then it drops real quick. It's called the dicrotic notch. And as Lisa's explaining, during that time, we're not moving anything. Okay? Not yet. So don't make it any harder than that. Okay? All valves are closed. Done.
Right.
Okay. Oh, speaking of valves, the last question talked about lub and dub, right?
Mm-hmm.
Right? Okay. What makes those two heart sounds? Lub dub, lub dub, lub dub.
Valves closing, or
I don't know. You gotta tell me. Okay, here we go. Wash my hands. Which one makes more noise? Opening or closing?
closing.
Always closing. Now, how many closing sounds do we have? Two. But how many valves do we have? Four. So what does that tell you?
Two.
Who closed? Two close at the same time.
Right.
Which two are closing first to make the first sound? Dub. I mean, lub.
The
Who were the first two?
The AV.
That's right, the AV valves.
Mm-hmm.
Got it? The AV valves have to close first because we've got to get the blood down into the ventricles. 10-4. Then when we squeeze the ventricles, the blood goes out to the lungs and out to the body. Then we close the SLs, and that's the dub. Okay? Now, what's a murmur?
It's when it's
That's cold.
not closing correctly.
Okay, a murmur is an extra sound
Oh.
beyond lub dub. Got it? Doesn't matter what the sound is, it's not just lub and dub. Got it? When the doctor hears my heart, he goes, "You have a murmur." I said, "Is it bad?" He goes, "No, it's not the kind to worry about." Okay? Now, usually it's caused by a stenotic valve. It's caused by some valve that's not closing properly. Oh, see, here's your dicrotic notch. See, whoop, down. Okay. All right. I think we had something about valves in here. Pretty sure we got some valves. Yeah, see? A stenotic valve or stenosis is a valve that's narrow. The opening is narrow. Okay? And it's usually caused by the fact there's something wrong with the flaps, the cusps. Notice how these all come together and pretty much close up. There's something wrong with these, it doesn't close up. Got it? And so it makes a narrowing hole here. Sometimes that sounds like squeak, squeak, squeak as the blood goes through that narrow opening. Got it? Other times, the edges clap against each other and the doctor can hear click, 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 click through the stethoscope. Got it? And there's other little things. Got it? Like lub dub swish, that kind of stuff. There's some extra sound because it comes from the fact, let's say you walked into a room full of people and they're all, can you tell what anybody is saying? No, they're all murmuring. See, you know they're talking, you just don't know what they're saying. See, your heart is making noises, it's just not, we don't know what the noise is. And that's why they do heart caths and whatnot, and they look at the valves to make sure they're closing. Because if you have a valve that's in really, really bad shape, we have to what? Replace it. Got it? Put in a cow valve or a cadaver valve to replace that. 10-4? Because this is the problem. We want our valves to close so we can send the blood out of the aorta, right? So we want this valve here, the mitral valve or the bicuspid valve, to close. What if the bicuspid valve doesn't close? It's prolapsed. See, we're going to send a lot of blood up the aorta, but some of it goes back into the atrium. That's not good. Then what about the blood trying to get here from the lungs? I can't take all the blood from my lungs, can I? Because there's already blood sitting in here. So it's going to back up in my lungs. Is that a good idea? No, that's going to be pulmonary edema. And if I don't send everything out to my body, then I'm going to have less oxygen. I'm going to have hypoxia. Does that make sense? Not enough oxygen being delivered because not enough blood is being delivered. So these are all things to keep in mind. So that's a prolapsed valve. Instead of, flapping like this, it's kind of like this. Got it? In the opposite direction. It's prolapse. It's inside out. And that's the kind that needs to be replaced. Does that make sense?
The pulmonary edema that's when the blood starts pooling in the lungs.
Right, but it's not the blood that's making the edema. The blood vessels are so full of blood that they leak. And what's leaking out is not actual blood, or you'd be spitting up red. Got it? No, what you're leaking is the fluid of your blood, the serum, the plasma. Got it? Mm-hmm. And that sits in between, the parts of your lungs, causing your lungs to become edematous. Does that make sense? Hey, while we're on the subject, let's answer the question about left and right-sided heart failure. Is that one of your questions there?
Yes.
Right. Okay. Left and right-sided heart failure. 10-4? All right. While we're at it. Oh, this is a little word here. Atresia. Something happened and your valve wasn't formed properly and it's blocked by solid tissue. Is that going to be helpful? No. You can't even get the blood to flow where it needs to flow. Okay? Because that's the purpose of your valves. One-way flow of the blood to prevent backflow to the chamber it came from. Got it? That's the only reason those valves exist. I want the blood to always go forward. Okay? All right. Let's go to left and right-sided heart failure since I brought it up. Okay. Here we go. Left and right-sided heart failure. Here is the way I explain it. I have a right side on my heart, and I have a left side on my heart. And the heart is like that rubber band. Got it? Either it's going to be strong, or it's going to be weak, and I can pull it out and it won't snap back. Got it? Have you heard, do you know what congestion means?
Think of like nasal congestion.
Yeah, so what should be in your nasal sinuses?
Air.
Air. And when you have congestion, what's it full of?
Fluid.
Mucus, fluid. 10-4. When you are having a traffic congestion, is it full of cars? As opposed to not full of cars. Does that make sense? Hi. Can you guys give me a few minutes?
I'm sorry?
Can you give me a few minutes? I'm tutoring my 211.
You know, take your time.
Okay.
We're scheduled for 2. You're good.
All right, thank you. He didn't get Check your emails. Anyway, so that's going to go on video. Great. Okay. Shows you this is a live class, not a dead class. Okay, so which side is this? Left side, right? This means this side is congested, meaning it's full of blood, and it's been weakened. The more your heart fills with blood, the more the walls get stretched. And instead of a bigger heart being a stronger heart, a bigger heart is a weaker heart because you stretch those muscles thin, like a balloon that's blown up too big, or a rubber band that's been stretched too far. Got it? It's been stretched out of shape. Well, sometimes it happens to both sides. We call that congestion. Got it? If it happens to one side, it's left side, right sided. Okay? So, here we go. Left sided failure. 10-4. Ready? Okay. Which side is working?
The right side.
The right. Where does the right pump blood?
To your lungs.
To your lungs. But guess what? The left side is too weak to receive it all. So it stays, it pools in your lungs, leading to pulmonary congestion or edema. Does that make sense? Okay, now
And
how
this
about
one's for the left or the right?
left sided failure?
Okay.
The right is working. See, that's the key. Don't worry about who's failing. Who's still working, that tells you where the blood's going. And where the blood is going is where the edema is going to be, because the weak side can't take it all. So, how about right-sided heart failure? If my right side is failing, which side is still pumping?
Left.
And where does the left pump?
To
The aorta and your body. But the right side is too weak to receive it all, so it pools in your ankles thanks to gravity. And now you get peripheral edema or congestion. Does that make sense? Yeah, your book calls it peripheral congestion. I call it peripheral edema. Same thing.
It's when your ankles and your feet swell up.
Yeah,
your
your ankles
fingers.
swell up and whatnot. Does that make sense? Now, what about poor grandma, where her lungs are getting congested and her ankles are swollen? Well, she's got both sides of heart failure. Got it? That's a dead giveaway. That both sides of her heart are failing because they're being stretched out. 10-4?
Let's see. Note the function of alpha and beta receptors on the heart.
Okay, I can do this pretty quickly without going to a slide.
Yeah, that was number 8, by the way, that
Okay.
you just answered. Okay.
Okay, that was number 8. Okay.
Mhm.
Now, alpha and beta receptors. If you remember your 210s, alpha and beta receptors are part of your sympathetic nervous system. So they react to epinephrine and norepinephrine. They receive that chemical. They are sympathetic, they are fight or flight. 10-4? Okay. Now, in particular, alpha receptors are on your blood vessel walls, and they constrict your blood vessels to increase your blood pressure. Beta receptors are on the heart, making your heart beat faster and stronger, also increasing your blood pressure. But that's the difference. Got it? Alphas are on your blood vessels, betas are on your heart. In particular. And they both react to epi and norepi. What would a person with a weakened heart, Mr. Weber, because of his heart attacks, what am I on? A beta blocker to try to keep epinephrine from getting to my heart, making it beat too fast. Does that make sense? We're not blocking all of it. You can't. I mean, I don't want to be, if my car is stuck on the railroad tracks and here comes a train, I don't want to be going, oh my, here comes a train,
Right.
I want to be, I gotta get out of here, right? But it's the everyday, I'm stuck in traffic. I don't need that. Got it? Somebody flunked my test. I don't need that. Got it? I've got to be a little more calm, and that's why I'm on a beta blocker. Okay, my heart's only working at 40%, so they don't want to overwork it, throughout the day. Does that make sense? I'm kind of even keeled here. All right.
What type of question would you ask about that on the test? Would it be like,
Which which receptor is responsible for
Blood pressure.
blood pressure, based on your blood vessels constricting? Alpha. Based on your heart beating faster? Beta. Betas are on the heart, alphas are on your blood vessels. But they're both fight or flight. They're both part of that. Does that help? Okay. What else, my friends?
Be able to discern between positive and negative inotropic
Aha.
agents.
I think that was right here. Okay. Positive and negative. Okay. Now, it's pronounced inotropic in some books and inotropic in others. This is what you are going to be calling it in nursing school. That's why it's in your book. All right. Ino means muscle fiber. And of course, what chapter is this? The heart. So we're talking about heart muscle. All righty? So, positive. Remember, in biology, positive means more, negative means less. So, these are the things that will make your heart contract more vigorously. Got it? Sympathetic nervous system, fight or flight. Certain hormones, thyroxine, epinephrine, and then of course calcium. An increase in calcium will also. That's why some people are on calcium channel blockers. Got it? Block the calcium from making the heart contract too hard. And other drugs, like you could give somebody epinephrine, you could give somebody digitalis, but those things will also make your heart beat harder. Got it? And faster. Positive. Got it? How about negative? Negative are chemicals or situations that are going to make your heart beat more feebly, less vigorously. Going into acidosis, having too much potassium in your blood. Remember, that's what slows your heart down and eventually stops your heart. That's the lethal injection we talked about. Okay? And, like I said, a calcium channel blocker. Got it? More calcium, more heartbeat. Less calcium, less heartbeat. Does that make sense? We can't eliminate calcium in your blood for obvious reasons. We need it for blood clotting and other things, right? But we can block the calcium from going to your heart in large amounts to try to slow the heart down. Okay? And again, I think they end in the word prill, like lisinopril or whatever. 10-4? So for the pharmacology classes that you'll be having soon. Okay? All right. Positive, right? Positive thoughts. You're going to make it. Did you already take your TEAS test or you're heading that way?
I was supposed to, and they told me to wait until I'm done with this class.
Okay. That's fine. All right. What else?
Right. When viewing EKGs, be able to recognize junctional rhythm, partial heart block, and normal sinus rhythm.
Perfect. Let's go back and do that. Happy birthday. All right. Yeah. I'll wait for you. You want me to keep going?
You go ahead.
Keep going? Okay. All right, my friends. This will be like one of your test questions.
Okay.
All righty? And all you need to do is be able to tell the difference between these. So the most important thing is, what's a normal EKG look like? All righty? Now, why is it called ECG and sometimes EKG? Anybody know? The German word for cardio is K. Okay? So, that's what I'm going to call it, because I've been calling it EKGs forever. So, this is normal. A P wave, a QRS, and then a T wave. Got it? P, QRS, complex, and then T. All right? And this is just the electrical signals of your heart. Got it? So let's go back and make sure we understand what each part is. If you remember biology 210, Bio 210 class, if you had your membrane and you have these little doors that open and close, do you remember when you were, back in September? That's Earth, Wind, and Fire. So, who's that? It's a famous band.
Oh, I told you.
You know who that is?
Yeah.
Good for you. Okay. All right. What are you on the outside, positive or negative, of your cell membranes? Always positive. Why? Because what's out here?
Sodium.
Sodium with a plus charge. So what does that mean the inside is?
Negative.
Always negative. When we depolarize, when we start making our first jump up, right, for our action potential, it's the sodium coming in making the inside positive. Got it? Well, I can't, and of course your outside, excuse me, becomes negative. See? We have now flipped the pole. Got it? We've depolarized. We've flipped these poles. How do I get everything back to normal? Well, because when you make your pole flip, that's the contraction. But I got to undo it. We have another chemical down here called K, which also happens to be positive. And he then floods out, causing it to be positive again on the outside, and we call that repolarization. You're back to where you were. Trouble is, sodium, does it belong in here? No. Potassium, does it belong out here? No. And so we have one more door that opens up called the sodium-potassium pump, putting everything back where it belongs. Got it? Okay. The key that we need to understand is the sodium coming in is called depolarization, and the potassium coming back out is called repolarization. Got it? And it's basically depolarization is going up and repolarization is going down. 10-4, up, down. Got it? Okay. When we are depolarizing the two atria, that represents the P. Got it? We are squeezing the atria. We are telling it electrically, you need to squeeze. That's this jump. Got it? Who's bigger, the atria or the ventricles?
Ventricles.
That's why when the ventricles depolarize, look how much bigger that spike is. Because it's a much bigger part of your heart, right? Okay. And notice this next jump here is the ventricles what? Repolarizing. Wait a minute. Don't my atria have to repolarize too? They're doing it inside this wave. That's why they call the QRS a complex. Because two things are happening at the same time. It's just that the ventricles are so much bigger, their spike, their action potential covers the repolarization of the atria. All right? And let me show you real quick here. I think. Yeah, see? My atria, see my SA note up here is telling this first atrium, you need to start squeezing, buddy, right?
Mm-hmm.
We're sending the electrical signal in yellow to get ready to squeeze. And notice, by the time we get both of our atria to squeeze, that's our first little wave. That's our P wave. Got it? And what's happening now? We are making our spike for our two ventricles to squeeze. But at the same time, who's depolarizing? The atria. Got it? But it's hidden inside here. See, here we are squeezing. And now, when we are starting to relax, there's your T. Got it? So even though we have four things happening, we only have three waves, three bumps. Okay? So that is a normal EKG. As long as you see those things on your EKG, we're in good shape. Okay? Now, let's take a look at this one. What's happening in this one? That's my QRS.
It's missing the P.
I got my T. Who's missing?
P.
P. Well, who determines the P wave? Which node is up here?
E. The AV.
No, not the AV. He's down here. The SA node. Got it? The SA node. Let me go back to those nodes here. See? The SA node, when he fires, he talks to the two atria. Got it? When the AV node fires, he talks to the two ventricles. No SA node firing. Got it? Well, the SA node is the one that tells the AV node what to do. So, if the SA node is not working, second in command is now doing it. So guess what we call that? Look at what words do you think it would be? Which one of these? Didn't we say look at the difference between the three?
Junction, the junction.
Yeah, it's the junctional rhythm. Why? Because the guy at the junction of A and B is now running the show. Does that make sense?
Right.
The guy at the junction. Okay, now remember, who wants to beat at 100?
The SA
Because
node.
they know.
Who wants to beat at 50?
AV node.
So if my SA node is not working, what will your heart immediately do? 50. And you can tell that's really slow. You're going, oh my gosh, what's going on? Okay? And that's why, if you look at your EKG, see how much longer it is before we get to the next beat? How much longer it is? Yeah. Does that make sense? I'm missing my P here. But aren't these waves bigger than these waves? Yeah. Stretched out more? Yeah. Because I'm really slowing down. See? The beep, 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 heart rate, beep, 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 heart rate. See how he's slowing it down? But the main thing is no P. Got it? No P. Now, what is happening here? Look at this. Ready? P, QRST. P, nothing. P, QRST. P, nothing. What is not firing? The what?
Is it the AV node?
Yes, now the AV node is not firing. But is it never firing? Every other beat is not firing. Does that make sense? Every other beat. What would happen if your AV node isn't working at all?
You died?
Yeah. Because if I don't ever squeeze my ventricles, is this blood ever going to make it to my brain to keep me alive? No. You know what we call that? Total heart block. So what is it when you're skipping every other beat?
Partial.
Partial heart block. Make sense? And here it is. It's not your AV node not firing. It's firing. I can't get the message down the bundle branches. There's something wrong here. Got it? Either the what they call the bundle of His, or all of them together, or the two branches left and right. There's something wrong, and we can't get the message from here down to the Purkinje fibers in the walls and stuff of the ventricles. Does that make sense? And it happens every other beat. Yes, ma'am.
So would that be the second degree of type 2?
I'm not going to get that specific for you. Okay? I'm just going to say, is it junctional rhythm, is it normal rhythm, or is it partial heart block? The answer is partial heart block. Now, yes, there are notes in here about first degree, second degree, winky back. Those are all words you're going to see in nursing school.
Okay.
Okay? I'm not going to get all twisted out of shape on your test about it. Okay? But I know that my nurses are always talking about winky back, winky back. Okay? This is the name of the guy who first discovered it, that's all. Now I guess the other guy's name is Mobitz. So, but the thing is this. When you first encounter having this partial heart block, it's very what? Mild. It gets worse because the interim stretches out further and further. And that's why in nursing school you'll have to count the squares. You know? How long before the next beat happens. Got it? Are you stretching it out too much? See? Signal gets slower and slower, slower and slower, 10-4. And that's what they're calling, type 2, type 3. But that's not on my test. All right, but it does exist, and that's why it does have it in the book. All right, come irregular and slower than normal, right? That's the problem.
Either one of the nodes not firing or
What do you mean?
doing like the
When the S8 doesn't fire, we call that junctional.
Mhm.
And when the AV node can't send the message, other than it's not firing, if it can't send the message down, that's partial heart block.
Okay.
either one of those would mean you'd need to get like a pacemaker.
Could very easily be. Yes, in fact, I think there's a picture of a pacemaker here. Yeah. Okay? Now, there's different kinds of pacemakers. Please be aware. Let me go to the one that I want to talk about. Oh, must be here. Yeah, this one. This one is for your partial heart block. Take a look at it. That's the machine that reads what's going on and sends an electrical impulse. Notice there's two leads here. Got it? This one is stuck in the AV node, and this one is stuck at the bottom where the ventricles are, right? It reads. Did the AV node get a message? And hey, did it make it down to the Purkinje fibers? No? Then let me charge them up. Got it? If this message gets through and it makes it down, then fine, I won't fire. Got it? So it's paying attention to what's going on. The other pacemaker that everybody is used to talking about, oh, did I go the wrong direction? The other kind of pacemaker is this, a defibrillator. You see, your heart should only make two motions, lub-dub. Two atria squeeze, two ventricles, lub-dub, two things, got it? What if your ventricles are doing this? Is that normal? That's called fibrillation. Your muscles are not squeezing all the way, they're partially and doing it out of order. Okay? Well, if that were happening at the hospital, what would you as a nurse do? Shock paddle, clear, and shock your heart into normal sinus rhythm. Got it? Well, if this happens to you as a patient so many times that you can't be rushed to the hospital every time, we insert this in here. So, with notice, it only has one lead going down to the bottom of the ventricle. Because when it determines that these ventricle walls are twitching instead of squeezing, they'll shock it. But this shock is just as hard as a shock paddle. It'll knock you, okay? But some people are so used to it that they'll go, hey, my name is Max Weber, how are you doing? And yesterday I went to, you don't even feel it anymore. You might be going like, oh, yeah, I've seen them going like, are you okay? He goes, why, what's wrong with me? Because it's happened so often.
Right.
But it's automatic. The heart pacemaker is going to make sure that we defibrillate it. Got it? It's not really a pacemaker. This is now called a defibrillator.
Right.
Got it? And it only fires when it needs to. 10-4? If it fires over and over and over again, I think a signal gets sent to the hospital that says that you're having a heart attack. Get the ambulance out there. That's the cool thing. And if you need to set any changes, back in the old days, you had to take it out, put a screwdriver in there and change the settings. Now, you just hold your cell phone over it, and the doctor on his cell phone will type in beep, 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 and it'll say beep, 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 and change the settings right through your skin. Okay? Which is really, really cool.
It is.
Cool beans? What's next?
One more quick question.
Yeah.
Are you going to ask on the test any questions about, like, obviously we should know it generally, but are you going to ask which one is the P, which one is the
Yes, yes,
QRS? Okay.
yes. The P represents what? Depolarization of the atrium.
Okay.
What does the T represent? Repolarization of the ventricle. What does QRS represent? Repolarization of the atria and depolarization of the ventricles. Got it? Does that make sense? Okay. Yes, I will ask you that. And when I said that we need to know that the heart only makes, See, normal, right? QRST. Missing the P and stretched out more. This is your junctional rhythm. Here's your partial heart block. I'm missing QRS. It's back. Then I'm missing it again. Got it? So a way of looking at this is are you missing all your QRSs? No. You're missing what? Every other.
Right.
But you could also say, don't I have twice as many P's? Right? 1, 2, 3, 4, but I've only got 2 QRSs, but I got 4 P's. Make sense? Okay. And this is fibrillation. See how it's all over the place, all chaotic? You know, I tell my students, this is test day. That's what you're always going to look at. Okay? But you see how this is not anywhere near normal and has to be shocked, either with the shock paddles or with an internal defibrillator, just to snap your heart back into its regular rhythm. Okay? All right. I think I saw a picture here. I must have passed it up. I just want to make sure we understand. Here we go. Remember, we only have 2 motions. Atria, ventricle. Atria, ventricle. We call that a syncytium because the prefix syn means together and cyto means cells. All of these cells, all these muscle cells, are working together. That's why they're bundled around the atria. And all of these muscle cells work together. That's why they're bundled around the ventricles. Because even though we have 4 chambers and millions of cells, we only have 2 activities. Atria squeeze, ventricle squeeze. Make sense? Okay. All right, you had another question, sir.
Oh no, I was just gonna say
okay.
the next one.
Next
We pretty much already went over this, but the difference between SA and AV nodes.
Okay, so as we said earlier, with our SA and AV nodes, we need to know who they are in charge of depolarizing. SA is for your atria, AV is for your ventricles. Your SA wants to go at 100, your AV wants to go at 50. Who makes you do 75? The vagus nerve, who says, listen here, buddies, I don't care what you want to do, that's what I'm telling you to do.
I have a question on
Yes.
that. So let's say your SA node isn't working properly.
Right.
And then the AV node would be in charge
Right.
at that point. Would the vagus nerve still make it 75?
No. That's when the vagus nerve says, I like 75, but AV is saying, no, now I'm in charge. Okay? But, how about this question? What if we cut the vagus nerve? What would happen to your heart rate?
Go to 100.
Go to 100, because now your AV says, free at last, I can do what I want to do. And it'd be got it? Have you ever heard those stories about the Mayans who would, cut the heart out of their enemies and you pull the heart out, and you can see it beating before you die? And 100% right. Your heart will continue to beat as long as it has enough oxygen and mitochondria and whatnot making ATP. So it'll be for a few seconds, and then it will eventually die. And your brain will still be alive too to see it. Not that I'm saying let's practice this right now, but okay? But that's it. And how fast would your heart be beating if you pulled it out of somebody's chest?
100.
100, because the vagus nerve is no longer in charge. Got it? You ripped it away from the vagus nerve. 10-4? Okay. Yeah, pretty gross, but there it is. What else?
Just to double check, that was all we really needed to know as far as the difference between the SA and AV.
Yeah, who fires at what, and what's your heart gonna do depending on the circumstances. Got it?
Mm-hmm.
So if your vagus is not working, SA is in charge. If your SA is not working, AV's in charge. Got it? So we got a 75, I got a 100, and a 50 as your 3 choices. Now please be aware, your textbook says somewhere between 75 and 100 beats. Got it? And this one's between 70 and 50 beats. Okay? So please, I don't want to be wishy-washy when I'm trying to teach. Let's just use the extremes as a way to explain it. High, low. 10-4. Just keep it simple. I mean, yes, there's ranges, but, How do you know when 70 stops and 75 begins? It's too close. 10-4, so that's why I'm not going to do that, even though your book says that.
All right. Next up, explain cardiac tamponade. Am I saying that wrong?
Cardiac tamponade. My notes are around here somewhere. Where are my... Alright. Your cardiac, your heart, there you go, okay. Is your heart covered in a sac?
Yes.
Yes, it is. It's a double sac. One touching the heart, one around the heart, with fluid in between. What other organs have a double sac?
Your lungs,
Lungs?
and your intestines.
Intestines. Now, why do all three of those organs have that double bag full of fluid around them?
They're moving. Or
They're
friction.
moving, so it's there to reduce the friction. Think about it. The more you rub, the hotter it gets, right? Well, I only rub for a few seconds. What are your lungs doing against your chest wall? What is your heart doing? Got it? It's constantly moving, so it's constantly going to get hotter and hotter. So we put that cooling bag of fluid. Now, what if that bag of fluid gets inflamed? We get an infection, pericarditis. Got it? Inflammation of the pericardium. We are going to end up filling that fluid. Is going to get more and more fluid, right? Remember inflammation, swelling, because there's going to be an increase in fluid, right? The 4 cardinal signs of inflammation. Well, that's pericardial effusion. We're going to build up fluid. When we build up enough fluid, it's now pushing on the heart, so the heart can't beat. And that's tamponade. Got it? There's so much effusion that is pushing on the heart itself, and the heart can't expand in order to beat properly. That needs to be drained off. And of course, whatever is causing the infection needs to be addressed. Big old needle. Take all that fluid out. Cool beans? What else?
Right. No EDV minus ESV equals SV.
Okay. Again, a mathematical equation, but no math has to be calculated. All right? You'll do enough math in pharmacology. Don't you worry about that. All right. Let's see if we can find. I know I have it in here. Okay, here we go. What's the most important thing to learn here? What do the letters stand for? Got it? V means volume, so it's amount of blood. Alrighty? S here is my stroke volume. It's the same stroke volume we had in the other CO equals HR times SV. It's how much blood comes out of your heart with each beat. Stroke volume. The volume with each stroke coming out. Okay? Well, how do I figure out how much is coming out? We base it on how much is in the heart when it's fullest and how much is left in the heart after we push it out. Got it? And that's what this means. Diastole is your heart at rest, which means fullest. Systole is your heart squeezing. Got it? So, and which part of your heart are we talking about? The ventricles. In fact, which ventricle only? The left. Because the right is going to your lungs. Do you put a blood pressure cuff over that? Over your pulmonary? No, you don't. So we don't really care about the rest of the chambers. There's only one chamber that's worth everything. The left ventricle is the one that sends it to your brain and your body. 10-4? That's what we're trying to figure out when we put a blood pressure cuff on your arm. What's coming out of my left ventricle? All right? So, that's what we're saying here. It's the most full when you're at rest, take away minus what is left after systole. That determines how much came out. Well, let's just do a quick math thing. If I have 100 milliliters in my full ventricle, and after I squeeze my ventricle, there's 30 left, how much came out?
70.
70. That's all it means. But don't confuse these two. I'm going to have you pick which one is the correct formula. Is it plus? Is it minus? Is it divided by? Is it backwards? 10-4? That's how I can tell you understand that this is the diastole, the resting volume, and this is systolic volume after systole. The end of systole, the end of squeezing. And we have to keep in mind, your lungs and your heart do the same thing in many ways. One of those ways is when you are breathing out, do you flatten out your alveoli every time? No. When you pump the blood out of your ventricles, do you flatten them out every time? No. It's like this. Got it? Full, not so full. Full, not so full. We always keep some blood to keep the shape of the heart. And it makes it easier with the next beat. And the same thing with your lungs. Your alveoli are like a balloon. You know? Once you blow it up the first time, you know, anybody ever blown up a balloon from a plastic bag? Isn't that hard? My first breath in there? That's like you as a baby taking that big first breath when you're born. Got it? But once your alveoli are open, we want them to stay open, just get bigger and smaller when you're breathing in and out. But it never collapses. Does that make sense? We've got to keep them, okay, with some fluid, air, inside, or blood. 10-4 is never flat. 10-4, that's always the leftovers. Okay, what else?
Know, kind of hit this already. Know the activities happening during the PQRST
Okay, we got that, yeah.
Next would be...
Oh, yeah, sorry, yeah,
It's kind of what this.
no, it's fine, yeah.
I didn't really understand what contractility is.
Oh, that means that your heart muscles are contracting. Yeah, it's how easy is it for your heart to contract? Okay, and it has to do with the Frank Starling law. Did you see the Frank Starling law? Yeah. See, this is like a muscle. The more I stretch it, the more it snaps back. Got it? This ability to snap back is contractility. Can I contract? Does that make sense? And the contractile cells are all the muscle cells of your heart except for the AV node and the SA node. Those two are called autorhythmic cells because they set the pace. All the rest of the cells have to be told when to contract by the pacemakers. They have no ability to do it themselves. But that's what contractility is. I stretched it out. Does it snap back?
And that law says it'll always...
And that law says that the more you stretch it, the more it snaps back. Just not overstretching it. Why? When you have congestive heart failure, not only do you stretch it, but it doesn't snap back because you're holding more blood with each beat. And the more you hold, the more congested your heart gets. And we stretch the heart out of shape, and now it's overstretched and it's been weakened. And that's congestive heart failure because your heart is filling with blood and we can't squeeze out what we're supposed to. Got it? If 100 came in and we pushed out 70, you got 30. Well, the next time you only pushed out 65, so now you've kept 35. And you only pushed out 60, you kept another 5. And you kept another 5. And your heart slowly gets stretched out. And that's what they mean by an enlarged heart. We don't want it to be larger than normal because it's weaker than normal, not stronger. Not the same thing as a skeletal muscle. Oh yeah, we want big muscles, right? Oh, we can be Arnold Schwarzenegger or The Rock, right? No. That's not how your heart works. 10-4. If it gets bigger, it's because it's been stretched out of shape by congestion. Cool?
So we hit the next one, which was discern between autorhythmic and contractile.
There you go. Okay.
And next is be able to explain the purpose of the valves of the heart.
Right. One-way blood flow. We don't want them to not work or the blood will go back where it came from, and that's not helpful. So you need to remember the order in which blood flows through the heart. So if I have a test question that says, what happens if your pulmonary semilunar valve is not working properly? You got to think, where did the blood come from before it went to the pulmonary semilunar valve? And the answer is
The body? No.
I'm gonna beat you.
I'm sorry.
Ventricle?
The right ventricle, yeah. Because
Okay,
from the
yeah.
right ventricle to the pulmonary, if the pulmonary isn't closing,
Yes.
it'll go back to where it came from.
Wow, I
Got
was
it?
thinking of the which valve would I be talking about if it's from the body?
There's from the body?
The tricuspid?
Yeah, but it wouldn't go back to the body. What it would do is instead of going down to the right
It would
ventricle,
go to
it
the
would
atrium.
back up into the right atrium.
Okay.
Yeah. It always goes back to the chamber.
Gotcha. Alright.
Okay, what else?
Know the main depolarization ion of the heart.
Okay, what did we say up here earlier? The main one in your skeletal muscles is sodium in, potassium out. Your heart is calcium in, potassium out. Got it? The primary one is the calcium, and then it's sodium. Okay? And that's especially true for the SA and AV nodes. They run on calcium. Got it? The rest of your contractile cells is back to sodium and potassium, but with some calcium. But the main one for your autorhythmic cells is calcium. Another reason we need calcium in the blood. If I don't have it, I can't work my heart properly. Okay?
Are you gonna ask any as far as the questions on the test, are you gonna ask anything other than like what is the main ion, or like would you ask something like I guess that I'm trying to think of something else that you would ask.
Something Weberian. Yeah.
Yeah.
Mhm. Oh, okay. Thanks
Yeah.
a lot. Well, at the moment, I think it just basically is saying which one of the following ions is the most important one for making your heart work.
I remember maybe it was in the video or on the slides, but she said something about how we have channels that'll open up. You have a slow calcium channel, high
Now,
calcium
that
channel.
we do. That we do have. I know I have it in here somewhere. There we go. Here we go. See? Okay. Your autorhythmics, SA and AV nodes, they have what?
Slow.
Fast calcium, slow sodium. Because they both need to come in, but who is the most important one?
Calcium.
Calcium. And then to repolarize, potassium comes out. For the rest of your cells, fast sodium, slow calcium, because the bottom line is, it's your autorhythmic cells need calcium more than the rest of your heart. Got it?
So
This is mostly sodium, some calcium. The autorhythmics is definitely calcium, some sodium. That's all.
would the contractile cells be in your heart still need more calcium than, like, let's say your muscle cells?
Oh, of course, yeah, because your
So-
muscles don't need calcium for depolarization.
No, so it's always
Your
more
heart does.
calcium.
Always need
it's just
calcium for
even
your heart.
more.
Just more for the autorhythmics, yes. That's why they have fast channels. Open it up, get the calcium in real quick. Got it? As opposed to open up and, come on in. 10-4? That's all.
Alright.
Good question, good question.
Explain the 0.1 second delay between the SA and the AV
Okay, we
nodes.
kind of touched on that. We want a delay so we had time for the atria to push the blood down into the ventricles completely. Yeah.
Nice and easy. And so if you ask a question on that, it's going to specifically be talking about getting the blood down from
Yeah.
the atrium to the ventricles.
Got to.
It won't be anything like the delay because it has to travel around the ventricle or anything like that.
Nope.
It's got to go down into the ventricle.
Okay.
Because if I can't get my blood into my ventricle and my ventricle squeezes before it's full, am I getting the full amount of blood out to my lungs and out to my body? No. And that's hypoxia. Got it? Less blood means less oxygen delivery to your tissues. And we don't want that.
All right. Next up, explain the fetal structures that bypass the fetal lungs and what they become after birth.
All right. That's pretty much the last thing, isn't it?
Other than the lub dub, which
Oh,
you
we
already
talked about it. Yeah. Okay. Well, super. I'm glad. All right. Here we go. Little baby, right? Okay. the lungs functional in a fetus? Why not?
Because you're getting oxygen from the mouth.
Yeah, but why not?
You're in the.
You're
So-
in the uterus. Any air down there?
No.
No. So what's the purpose in trying to make the baby breathe?
Right.
Got it? So they're dormant. The lungs aren't really functional. However, if we look at a heart model, I'll walk over here. Pardon my squeaky shoes. But do you see this little bridge here between the pulmonary trunk and the aorta? Okay? Between the pulmonary trunk and the aorta. Got it? You see that here? That little bridge there? Okay. That one right there.
Right.
Aorta, pulmonary trunk.
Okay.
All right. Think about it. Where does the blood from the pulmonary trunk go? To your lungs, right? Well, the fetus's lungs don't have any air. So should I send blood there? No. So this is actually a much bigger ductus arteriosus, and the blood goes straight into the aorta. Because the baby's blood is not blue here. Mom's already made it red for the placenta. So there's no need to send red blood to the lungs, so we send it straight to the body. 10-4. But here's the miracle of miracles. The moment you take your first breath, this closes up. It closes up immediately, and it forms what's called the ligamentum arteriosum. So instead of a duct, it becomes a ligament. Okay, because it's just a bunch of muscle tissue. And just like ductus, arteriosus rhymes, the ligamentum arteriosum is going to rhyme as well. Does that make sense? Okay. So that's what it becomes. Is that the only thing? No. Your heart has another way to bypass the lungs. So let's open up the left atrium and let's open up the right atrium. If we look inside here, you tell me if you can see this. Do you see this oval-shaped dip here? That is a hole that goes all the way around to this dip here, and it's a hole between the two atria. Okay? So you see that one right there and this one right here? See that dip right there? And that right here? And the same thing. See that dip right here? And that one on that side? That used to be a big hole. For the exact same reason we had this. As soon as the blood comes into the right atrium, the blue blood, well, it isn't blue because mom's already oxygenated it. Why not just send it right across to be sent out to the body? Got it? And this hole is called foramen ovale. Foramen means hole. Ovale means it's oval shaped. But again, miracle of miracles, the moment you take your first breath, it closes. And the only remnant we have is the fossa, F-O-S-S-A, dip ovalis, the oval dip, which you can see on both atria. Got it? But it's closed. What happens if that hole stays open when you're born? Now the blue and the red blood do mix, and you end up with a blue baby. That's why the baby looks blue, or has tinges of blue. Okay? I don't think anybody comes out like a blue peep or something. But it's because the blood is mixing. Well, why is the blood mixing? Because that hole didn't close. Got it? Now, back in the old days, you had to wait several years for the child to be strong enough to handle open heart surgery, because you had to do it by hand. Okay? Well, now we can do it with microsurgery, where the doctor is using a joystick and looking at a computer screen, and little tiny scalpels and things are down in there sewing it together. Okay? Inside the heart with tiny little threads and tiny little instruments. Okay? We call that microsurgery. 10-4. And that's why a lot of doctors who specialize in microsurgery used to be gamers. Because they have good eye-hand coordination. 10-4. Their eyes see it over here, but then their hands know what the joystick needs to be doing. Does that make sense? It's really, really cool. It's amazing how that's the new frontier. Alrighty? And we can start doing surgeries in utero. Got it? Now we don't have to until the baby's born, obviously, but then we can do it. Okay? Now this, not that this is on your test, this is a really bad situation. Look at this poor baby. He has a problem called tetralogy. How many things are wrong with him? Tetra is 4, remember? Because tetra is what's Tetris? The game where you stack little bricks? 4 sides on each brick. Got it? That's called Tetris. He's got 4 problems. There's a hole in his ventricles. There's a problem with his pulmonary valve. There's a problem with hypertrophy of the ventricle and an overriding aorta. Okay? So you've got a problem 4 ways for this poor child. Okay? That's lots of operations and stuff. 10-4, tetralogy. That's pretty much it, though. See? Ding. Is that all of it, my friends? Any questions? Anybody? You sure? Okay. Good? Okay. See ya. All right. We'll